Well, good morning, everybody. Welcome to Grand Rounds. It's my pleasure to introduce Dr. Ayush Cole. It's one of our third-year pediatric residents. Ayush is actually going to Edmonton next year to do pediatric critical care, along with another one of our R3s, Madeline Bohr, and we've started a GoFundMe page to raise money for thermal underwear. I think it's like -50 today in Edmonton, something like that. So just so you know, Ayush, we're looking out for you and Madeline. Today's topic, as you can see, is traumatic brain injury, and Ayush is going to talk about some of the management perspectives. From what I understand, probably about 1 in 2,000 Nova Scotians every year sustain significant head injuries, either through falls or motor vehicle accidents, most of which are preventable. So lots of work to do in terms of both preventing and knowing what to do. If you are a community pediatrician in one of our maritime regional centers, you may see one of these children or youth in the emergency room as part of the initial trauma team. So we look forward to what Ayush has to teach us today. Ayush, the floor is yours.
Thanks for the introduction, Dr. Link. Thank you. As Dr. Link was saying, my name is Ayush. I was going to present on traumatic brain injuries and intracranial pressure management in pediatrics. It's an interesting topic because there's a lot to learn from it, especially about physiology. And it's a very important topic that I wanted to cover. In regards to the objectives of my talk today, I was going to talk about the classification of traumatic brain injuries and how we do that. Indications through imaging and what's coming down the line. Specifically, I'm going to talk about the catch versus the PCAM. And then the bulk of my presentation is going to be about principles of severe traumatic brain injury management, and mostly about what we should know about the community and what the goals of it are. And then I'm also trying to focus on the physiology of why there's increased intracranial pressure and what's the physiology of the management. In regards to traumatic brain injuries, as Dr. Link said, it's quite common. More than 20,000 cases per year come to the emergency department in Canada alone with traumatic brain injuries. They do vary quite a bit in severity. Luckily, vast amount of them are actually concussions, about 80 to 90%, which is good, which would be mostly mild traumatic brain injuries, but they can be quite significant, including intracranial bleeds. Those have very significant morbidity and mortalities associated with it. Children in particular are at higher risk and are more prone to TBI, and it's because of this unique anatomy. Mostly it's due to their large head to body ratio, less myelinated neuronal tissue, and thinner cranial bones. This makes them more prone to shear injuries and injuries such as diffuse axonal injuries, which are poorer outcomes. And they also are at higher risk of secondary cerebral edema because they have more fluid in the brain compared to adults. The one thing that is protective, however, in kids is they do have more neuroplasticity, so sometimes their outcomes are much better than in adults. But overall, these pose a higher risk in children compared to adults. Quickly talking about the causes of head trauma, specifically in Canada. By and far, it's blunt trauma, falls being the most common thing we see. Other ones are sports-related injuries, injuries involving bicycles, especially when they're not helmeted. Injuries involving motor vehicle accidents, and non-accidental trauma, unfortunately. Non-accidental trauma, as you're aware, is more common in little children, but it can present in any age. In other places, there's other types of head trauma. Unfortunately, you can get it from projectiles, you can get it from blast explosions, you can have it from penetrating injuries, though it's much less common in Canada. Just quickly talking about classifications. The classification is actually done mostly based on the Glasgow-Coma scale. Just so we're aware, it's not as accurate in younger children, but it's still what we use. Typically, what we look at in Glasgow-Coma scale is looking at eyes, verbal, and motor in response to stimuli such as voice or pain. Most of our, as I mentioned, are mild traumatic brain injuries, and they usually present with a GCS of 14 to 15. And that classifies as mild. Moderate is more closer to 9 to 13, and severe being less than 8, which have significant morbidity and mortality associated with it. Majority of my presentation is going to actually focus on severe traumatic brain injuries and the management of that, because those are the ones that are poorer outcomes, and those are the ones that require ICU level care. In regards to clinical manifestations of TBI, initially they can present as several different things. They come as headaches, amnesia, altered level of consciousness, vomiting, blurred vision, and seizures. There's a wide variety of, as I previously mentioned, of traumatic brain injuries and what's classified as such. It could be anywhere, as I mentioned, as a concussion to other injuries like subdural hemorrhage, epidural hemorrhage, diffuse axonal injuries, and so forth. The most ominous signs to look for intracranial injuries, such as bleeds, are looking for prolonged loss of consciousness or impaired level of consciousness, disorientation and confusion, worsening headache, repeated or persistent vomiting. These kids warrant further imaging and further workup. In regards to what kind of workup, by and far it's neural imaging, and CT scan is the modality that we usually pick. CT is what we usually pick because it's much quicker than an MRI. Though an MRI can give you more information, a CT tells you what you need to know, and time is quite important. Essentially, you go into the imaging to see what kind of lesion it is and what kind of interventions you need. You want to see the extent of swelling, whether at risk of herniation, and if there's a bleed and the need to go for urgent neurosurgery. So CT is the best way of doing that, as opposed to MRI, which takes much longer. You may still need an MRI down the road, but start off in the trauma bay with a CT scan. Skull x-rays really do have a limited role, but you can use it if you have a suspected fracture. But again, if you do have a fracture, you're going to go on to have a CT scan anyway, so you can forego that and go straight to a CT scan. In regards to who should get a CT scan, anyone with a moderate or severe TBI should go for a CT scan without question. And then the minor head injuries, there's special rules established. The CPS statement actually on traumatic brain injury talks about the CATCH rule, is the one that they primarily use. But that's changing, which is something I was going to talk about. In regards to the CATCH rule, it was from the Canadian assessment of, it was on a Canadian study that essentially looked at kids with minor head trauma within the first 24 hours to see if they needed imaging or not. And this is what they found. They described the high-risk group as being, a GCS less than 2 hours after injury, suspected open or depressed skull fracture, history of worsening headache, or irritability on examination. All of these automatically go to CT scan. And if that doesn't work, you look at your medium risk, which includes signs such as basal skull fractures. And the signs you'll be looking out for are hemotympanum, meaning blood behind the eardrums, raccoon eyes, meaning darkness under the eyes, autouria or rhinorrhea of cerebrospinal fluid, or battle sign, which is bruising around the mastoid process. You can also look for large boggy hematomas of the scalp, suggesting there's a vessel that's been damaged, or you can look at the mechanism itself, which we'll talk in a bit. However, I was actually talking to one of the people who were involved in the acute care management of community in CPS, and they're suggesting the new guidelines which are coming out soon is actually going away from the CATCH rule and is going towards PCARN. The reason being PCARN is found to be more sensitive. A recent study done in a US center of 1,000 patients essentially showed PCARN is way more sensitive. It's 100% sensitive as opposed to CATCH, which is about 90 for catching these injuries. And PCARN is also more accurate than anyone who's less than 2 years. So essentially, this is the PCARN rule. As you can see, it's quite similar to the CATCH rule, but it's divided into 2 different ages, less than 2 and older than 2. In regards to less than 2, you look at altered level of consciousness, GSS less than 15, and palpable skull fracture, and they all go on to have this imaging. And then if they don't have those, you go into the next criteria, which is loss of consciousness more than 5 seconds, non-frontal hematoma, not acting normally, or severe mechanisms. And the severe mechanism is quite similar. This drawing is kind of nice because it shows you in the bottom. Essentially what it shows is if you're getting ejected from a car, if there's a death of the passenger, if there's a rollover, if it's a bike accident where you're not wearing a helmet, if it's a fall from greater than 3 feet, or if it's a heavy weight that's falling on your head, you should go on to have a CT scan. In regards to the 2 year older than 2, it's pretty similar, as you can see. The only thing that changes is from skull fracture, you go to a basal skull fracture. And then the severe mechanism is essentially the same. The height just changes to about 5 feet. So that's essentially what I wanted to talk about mild traumatic brain injuries. The most of this presentation is going to be from the guidelines that was recently published in 2019 from the Pediatric Critical Care Group. And the guidelines focuses mainly on severe traumatic brain injuries and the ongoing management, in particular about the intracranial pressure and secondary damage. In regards to a severe traumatic brain injury, the primary goal is always to stabilize them in the trauma bay. As you can imagine, when you have a severe traumatic brain injuries, there could be a whole host of other injuries, especially when you consider a fall or MBC accident. So you do follow the ATLS guidelines and go through your primary and secondary surveys to make sure that you identify other injuries and treat it quickly. You still follow the same rules and go through your ABCDs, and you don't progress the next step unless one's cleared. And by the ABCDs, I mean airway is the first thing you manage to make sure they have an adequate airway. And vast majority of them require intubations because they have decreased level of consciousness. Then you look for anything for breathing issues, such as pneumothoraxes, and then you look into circulation. It's really difficult sometimes in trauma when you have two concurrent injuries, such as a significant TBI and a intra-abdominal hemorrhage, but you want to make sure you treat the hemorrhage as it'll worsen your TBI. And the primary goal is always to take care of circulation before you move on. Sometimes they do concurrent ORs where they go for craniotomy at the same as a trauma laparotomy, but again, it depends. Otherwise, all these patients do need a consultation and refer to a trauma center with neurosurgical and a pediatric care service because they need constant monitoring. And the goal of a TBI, the idea behind it is that when you have a traumatic brain injury, you have an initial impact and there's the amount of tissue that's already damaged that's not going to be recovered. The vast goal is to prevent the secondary damage to the area that's vulnerable around it, which is called the penumbra. In regards, just a quick plug-in from our ICU group, essentially anytime you have a severe TBI, you need to make contact with both the trauma team and the pediatric care team, just so they can guide you through management, especially when there's multi-system injuries. The secondary injury, also I forgot to mention earlier, can be due to a couple of different things, usually due to vasogenic edema or cytotoxic anemia. The vasogenic edema essentially means that their blood vessels are affected and there's capillary leak leading to more cerebral swelling, while cytotoxic edema at least means swelling of the actual cells itself, causing further damage. An important concept when managing intracranial pressure is the Monroe-Kelly doctrine. The idea being that the intracranial vault is a fixed space and there's three components in it, which is the brain, which comprises about 80%, CSF, which is about 10%, and cerebral blood volume, which is about 10%. Anytime any of these are increased, there has to be a reciprocal decrease in the other two, and that's the idea behind the doctrine. As you can imagine in trauma, any of these three elements can be affected. You can have a hemorrhage causing decrease in your cerebral blood flow and your CSF and brain, or you can have brain swelling causing decrease in the two. So it's really important to prevent this. And the idea is, as your ICP increases, the end result will be cerebral herniation, and that's our goal is to prevent that because it leads to a much worse outcome. In regards to what's normal for intracranial pressure, in adults, it's usually less than 10 to about 15. In kids, it's 3 to 7, and term infants is 1.5 to 6. What we target when you have an ICP monitor is an ICP less than 20. It can be transiently higher, and as you can imagine, even in normal people, it can go transiently high, but the goal is it should not be higher than more than 5 minutes. And you really need to treat it if it's sustainably high of more than 5 minutes. Otherwise, the other key concept in regards to intracranial pressure is about cerebral perfusion pressure, and that's the blood flow that's going to the brain. To calculate that, it's actually looking at your blood pressure or the mean arterial pressure minus the intracranial pressure, and it's a difference. So as you can imagine, if you have a high ICP, you're going to have a lower cerebral perfusion pressure because it's going against your blood pressure. And subsequently, sometimes when you have a low blood pressure, such as hemorrhagic shock, you're also going to have low cerebral perfusion pressure. The goal of CPP for infants to 5 is greater than 40, for about greater than 50 for anyone for 6 to 17, and greater than 50 to 60 for anyone who's older than 17. As I previously mentioned in the slide, as you get older, you aim for a higher cerebral perfusion pressure. The next thing I wanted to quickly talk about is about ICP monitoring. Again, it's not going to be done in a community setting. It's more for the ICU, but it's important to know what kind of ICP monitoring we usually do. Typically, this is inserted by a neurosurgeon, either in the operating room or in the bedside itself. There's a couple of different ways to do ICP monitoring, but the gold standard by and far is intraventricular device. In regards to that, what we usually try to do is try to insert a drain into the foramen of Monroe around in the ventricular space. This is the gold standard because it allows for two things. It allows to actually monitor the ICP and also to manage the increase in ICP. Because as you can imagine, it's a drain, and if you have a high increase in your ICP, you can let the CSF flow out of it to decrease the ICP. However, in trauma situation, this is not always possible. The reason being the brain is swollen, everything's distorted. So as you can imagine, the ventricles can be quite small and difficult to get access to. So vast majority of times what we end up inserting are the intraparenchymal or subdural ICP monitors. And they do provide accurate readings, but again, you need to take it in a clinical context, but there can be issues with them. From talking to the intensivists, our ICU typically uses the intraparenchymal ICP monitoring. So I know this is a busy slide, and this is going to be the focus of my presentation, where it's this is the new algorithm that came up from that consensus guideline that was published in the Pediatric Critical Care Journal. The next part of and I'm going to go through each step of this and explain the physiology behind it, the idea of what we should be doing. But the bulk of my presentation is going to be around baseline clear and herniation pathways, because they're the most important to know as an emerge doc or a community pediatrician, because this is what you might have to manage. In regards to the baseline care, there's 9 critical steps, which I'll go stepwise to explain what we should be aiming for. And this should be for anyone who's coming with a severe traumatic brain injury. The first step is always in regards to managing their analgesia and sedation. Analgesia and sedations are important for so many different reasons. One of the big ones being that it can actually increase your ICP on its own. Pain, as you can imagine, it does increase your cerebral metabolic demand, can cause increasing cerebrovascular blood flow and cause an increase in ICP on its own. Moreover, it can cause you to bear down, essentially increasing your intra-abdominal intrathoracic pressure, which essentially are linked with your intracranial pressure and can drive it to go higher. Moreover, agitation and anxiety does the same. And then ventricular dysynchrony is also important. When they're not properly sedated, anyone will try to fight the ventilator, and this leads to an increase in intrathoracic pressure. And as I kind of alluded to, when you have an increasing intrathoracic pressure, it leads to an increasing intracranial pressure because they're all interlinked. Therefore, the goal in the vast majority of time is to make sure these patients are well sedated and pain-free to avoid all this. There's also long-term sequelae that we have to look out for, because chronic pain in these cases can lead to psychological trauma and pain issues down the road after they're out of the ICP. Sometimes when they do have no response, unfortunately, some of these patients can present with herniation that's already done, and they can present with brain death. In that case, you don't necessarily need to sedate them, so you need to assess them prior. The other important concept is when you sedate these patients, you want to use a short-acting sedative, because you want to be able to let the neurosurgeon or the ICU team be able to assess their GCS once they get to them. In regards to the choice of sedation, there's mostly just level 3 evidence out there. In adults, by and far, what they use for sedation is propofol. Propofol is a really nice drug because, as I mentioned, it's very short-acting and works great for sedation. In adults, you usually use a combination of propofol and fentanyl, but in kids, it's generally not recommended, especially prolonged use of propofol. You can use propofol in the mean term for intubations or short procedures, but you really shouldn't leave them on an infusion. The reason being they have a high risk of propofol infusion syndrome, which in itself has a really high mortality risk. Typically, what most of the guideline recommends is using high-dose fentanyl and midazolam, as both of them, again, are short-acting and work great for sedation and pain control. And there's been an interesting study that was compared fentanyl to hyperosmolar therapy. And what they actually found was fentanyl actually does decrease ICP, but only in the context of pain and agitation, and is not as effective. But again, it can have some role in ICP management. The other key concept is to think about the side effects of these medication. The main thing being hypotension, which again, as I mentioned, decreases CPP. So that's why you try to avoid bolusing high doses of fentanyl and midazolam, because it can actually lead to hypotension. And As opposed to that, we usually try to run infusions at high doses to make sure the patient's well sedated. Back in the day, there used to be literature against contraindications against ketamine. That has since been disproven mostly. Back in the day, we used to think that ketamine used to actually lead to increase in ICP, but that has since changed. Ketamine is a great drug for intubation and sometimes can be used when there's hemodynamic concerns. But again, the use of ketamine still varies from practice to practice, but the literature currently states that ketamine does not have any particular effect on ICP. It doesn't increase it or decrease it. The other concept that you have to think about when you're doing sedation is neuromuscular blockade or paralysis. Usually use drugs such as succinylcholine or rocuronium for that. You don't always need this kind of medication, and you usually try to get away without it because it has its own risk to it. The main thing is because it takes away your clinical assessment, and you don't know, it's very difficult to assess the level of sedation. But sometimes you do need it to talk about to manage the ICP. Usually it's in the cases of where there's shivering occurring, which I'll talk about later when that'll occur. And in regards to when there's significant ventricular desynchrony, you might need a neuromuscular blockade. Also, sometimes you use it to sedate the patient or to paralyze the patient more to ensure that there's no continuous increase in ICP. The other times these medications are used is during intubation. So you do try to optimize your intubation as much as you can with these patients. So, and neuromuscular blockade is a key part of that. Usually you try to use a drug such as rocuronium, which is short acting during intubations, because you want to make sure you're giving your best attempt, and the paralysis will help with that. And just talking about intubations, these are the indications of when to intubate a head injury. Essentially, it's quite similar to the same indications to anyone else. Things that you think about is upper airway obstructions or loss of airway protection, which can happen due to loss of pharyngeal muscle activity and tone, inability to create a secretion. And as you can imagine, when you have a trauma, such as a projectile, you can have a foreign body. You can also have a direct trauma to the neck, leading to a hematoma that's expanding. You can also have issues with your chest wall, leading to breathing difficulties, such as when you have a flail chest, meaning that there's bilateral rib fractures. They can have respiratory muscle dysfunction. The other things you want to avoid is hypoxia and hypercarbia, which we'll talk about in my next couple of slides. You can also need intubations when you have anisocoria, meaning one pupil is greater than the other, or low GCS again, which is in the idea of unable to protect their airway. General rule being GCS less than 8, they should get intubated. The other important things about intubation, as I previously mentioned, intubation is a high-risk time in a couple of different ways. One idea being that this is a time that they could be hypoxic, so it's really important to pre-oxygenate these patients before you intubate them. And the other concept is you want to make sure they're well sedated, even if they have a low GCS prior to intubating them. The idea behind that is that direct laryngoscopy is very stimulating for a patient. It causes a sympathetic response leading to an increase in your blood pressure and ICP, and then can also increase your intrathoracic pressure. So you want to make sure these patients are well sedated and you take your best attempt because there can be a lot of things going on when you're trying to intubate them, and they can have other complications such as a C-spine collar or an expanding hematoma, as I mentioned, making the intubation very difficult. In regards to mechanical ventilation, there's a couple things you aim for. And even if you're not mechanically ventilating, you try to keep you want to avoid hypoxia at all costs, and you aim for a SAT greater than 92. The old guidelines even say greater than 94 because you really do want to avoid further ischemic injury from the hypoxia. The other thing that hypoxia does is increases cerebral vasodilatation, which in turn increases your ICP. So you want to avoid that. You also need to prevent hypercapnia. And the idea behind that is that a higher PCO2 will decrease your, increase your your cerebral perfusion, increasing your ICP. You also aim for a pH 7.35 to 7.45, and you decrease your PCO2 result leading, and you can decrease your PCO2 to lead to vasoconstriction to help with your ICP management. Speaking specific to that, hypoxemia, it's something as I previously mentioned, you really want to avoid. Your main risk for it during the initial injury itself, when you have a downtime, or during transport, or when you're trying to intubate. So you really want to avoid this at all costs. The hypoxia will make things worse and lead to increased damage to your secondary area. So you want to avoid this at all costs. To manage your hypoxia, the two main things you think about is your fraction of oxygen and your mean airway pressure. In regards to your mean airway pressure, the two things you can play around with is PEEP and PIP. PEEP means positive end expiratory pressure, and PIP means positive inspiratory pressure. The main difference you'll see is when increasing your PEEP, meaning that you're increasing your intrathoracic pressure. So you have to balance the PIP and the FiO2. You can increase your PIP to generate more pressure, so you can open up more of the alveoli to help with oxygenation. But at the same time, as I previously mentioned, you have to look at your intrathoracic pressure at the same time, and you try to minimize that, because increasing your intrathoracic pressure will increase your ICP. At the same time, a high FiO2 can be useful to maintain oxygenation, but you try to lower it to less than 50%. The idea being that when you have high FiO2, you actually produce oxygen radicals, and that can actually do further damage to the tissue. So it's a constant balance between managing your PEEP and your FiO2 to maintain hypoxia, prevent hypoxia. In regards to hypocapnia, there's level 3 evidence looking at hypocapnia versus normal PCO2. The goal they found is 35 to 40 as per the new guidelines. Sometimes you need to induce hypocapnia for prolonged times when you have sudden increases in ICP, which we'll talk about later, and this is more a second-line therapy. But in the short term, if you see any signs of herniation, you try to drop your PCO2 as much as you can to prevent herniation. However, you do need to take this as a caveat, because when you use it for a prolonged time, your PCO2 less than 30 can actually lead to cerebral ischemia, because it leads to significant vasoconstriction. So again, it's always a balancing act to see what you can do. But in general, you try to aim for 35 to 40 initially. This is a great slide, and I really like it because it kind of describes everything I was talking about in the last couple slides. As you can see, the brain generally has an autoregulation where it can manage itself. The important thing to know about in TBI, this autoregulation sometimes can be off, and you don't know where in this curve you can be. But basically, it kind of shows you what happens with your PaCO2, which is the yellow line, PaO2, which is your blue line, and your cerebral perfusion pressure, which is your green line. As you can see, as you increase your PaCO2, you start getting more vasodilatation. As I mentioned, as you vasodilate more, you start having increase in your ICP. So you want to avoid that. So you'd want to go the other way. In regards to PaO2, as you can see, at a high PaO2, you have vasoconstriction because your brain is getting oxygenated. But as this drops, you vasodilate, try to increasing your perfusion, and in turn increasing your ICP. So low PaO2 leads to that too, which are both very key concepts in managing ICP. The third part of the talk is the guidelines is about normothermia. You want to make sure all these patients are normothermic, but the main goal is to keep their temperature below 38. By normothermia, I mean temperatures are usually around 36.5, 37.5. The reason being, again, high temperature leads to increased metabolic demand, increasing vasodilatation, increasing ICP. You need to manage in several different ways. If you have issues and you're having difficulty controlling temperature, you can use a cooling blanket or antipyretics such as Salinol to help with that. The other thing, when you do use a cooling blanket, you can start getting shivering. Shivering can also lead to increase in ICP. Therefore, it's important if you start having shivering to make sure your patient gets paralyzed with something like rocuronium. This is more second line, but it's important to think about, and this is where the literature comes from. It's in regards to looking at hypothermia and ICP management. There's, again, just small evidence looking at 5 low-level RCTs, looking at hypothermia, where their targets were 32, 33. They found there's actually no overall difference in outcomes when you induce early hypothermia versus normothermia, and that's why we suggest normothermia nowadays. Moreover, however, when you have refractory increase in your ICP, hypothermia may be important. In regards to that, what they found was then they induced hypothermia, and I think their targets were more 34 to 35. They actually found that they did lower refractory ICP, and this is more so with the ICU. And however, there's only a limited effect. It lasts for about 5 days and subsequently has no effect afterwards. The one thing to know about it, though, when you induce hypothermia, is you can need increased pressors, such as a NOR-epi or epi. But again, all of this is level 3 evidence, but that's the best we have currently. The other important concept is about intravascular volume status, especially in a polytrauma patient where you can have hemorrhagic shock and so forth. As I previously mentioned, you really want to avoid that, and you want to make sure they're well resuscitated. You want to ensure they're not hypovolemic or hypotensive, as again, that will drop your cerebral perfusion pressure, further worsening your secondary injury, secondary to ischemia. Hypertension is also important to avoid because hypertension will also increase your ICP. Again, going back to that equation of CPP equals MAP minus ICP. When you drive up your MAP, you're going to increase your CPP, which in turn can drop your ICP. Again, the other important thing about hypertension is you also increase the chance of bleeding in an already vulnerable brain. In regards to perfusion, we measure with different markers. The main important one we use is urine output. So usually insert a Foley in that case. You also look at other biomarkers such as creatinine, urea, and so forth. And sometimes you need invasive monitoring, such as central venous monitoring. At the same time, when you try to resuscitate, there's been studies done to see what kind of fluid. Generally, we recommend normal saline because you do aim for a higher sodium level, at least above 140 in these patients. There has been other studies looking at other things. There's actually another trial called the SAFE trial looking at albumin. It actually showed there was no worse outcome with albumin compared to normal saline. So again, crystalloid is the way to go, and normal saline is usually what they recommend. There were other studies that looked at ringer's lactate versus normal saline, and they found that the normal saline group also did better. So that's generally the fluid we recommend. The fifth concept, again, is to ensure there's adequate hemoglobin. As I mentioned, when these trauma patients, they can have significant hemorrhagic shock and bleeding, leading to a significant drop in hemoglobin. So you want to make sure if you need to activate a massive transfusion protocol or anything, to aim for hemoglobin above 7 grams per deciliters, which is important. This is actually a consensus. There's no clear evidence specifically for intracranial or traumatic brain injuries, but it came from a landmark study in pediatric ICU based off the TRIC trial, which was on in the adult ICU. We call it LaCroix, which was published in 2007 in New England Journal of Medicine, which essentially looked at liberal versus conservative transfusion. And what they found was when you transfuse a 7 grams per deciliters aside instead of 10, you had lower needs for transfusion and had the same outcomes. But the one thing to know about this is that this was done in stable patients, who were already in the ICU for 48 hours. So this may not particularly be true for unstable patients. And if they're unstable, you might need to aim for a higher hemoglobin. But as per the guidelines as it sits right now, this is what the targets are. The other important concept is to treat coagulopathy. This is, again, to prevent further worsening intracranial bleed. You also want to make sure your coagulopathy is normal before doing any neurosurgical procedures. Particularly, you want a platelet above 100 and iron less than 6, so you can give them vitamin K, platelets, or plasma to help this. This is especially important in cases such as when you're doing a massive transfusion protocol, when you're giving massive amount of blood products. You want to make sure you're getting all the other units so you don't have a coagulopathy associated. The other thing is there is something called the lethal triad in trauma, in initial trauma, which is a state of hypercoagulopathy, hypothermia, and acidemia, and it's something you really want to avoid because they have really poor outcomes secondary to this. And in this case, you want to make sure they're stabilized and correct them as much as you can before you do any kind of intervention. The seventh point is quite easy. It's about head positioning. It's something very simple and easy to do. Essentially, you want to make sure all these patients' heads are raised to about 30 degrees. Make sure their head's neutral, meaning they're midline with no obstruction. There's a couple of different reasons for this. One, the head positions actually decrease your ICP. It allows for gravity to allow for venous drainage from your head, decreasing your ICP in that sense. Also, it prevents microaspirations when they're in the ICU for a long time. And those are the things. The other thing to think about when you're talking about head positionings is to make sure there's no venous obstruction. This particularly is when you have a concurrent C-spine injury with TBI. In that case, they usually have a C-spine collar. So you want to make sure they're not tight so it doesn't cause venous obstruction and lead to an increased ICP. The 8th point is in regards to seizure prophylaxis. Seizures more common in children compared to adults because they have a lower seizure threshold in traumatic brain injuries. The highest risk is in the first 24 hours. And seizures in traumatic brain injuries can classify in two different ways. It's either described as early, which occurs in the first 7 days, or late, which occurs after 7 days, and can even be labeled as post-traumatic epilepsy. Post-traumatic epilepsy occurs in 10 to 20% of the patients. And to monitor for this, some guidelines actually suggest that we should do EEG monitoring in this patient, especially when they're sedated and paralyzed, where you can't clinically assess seizures. In regards to risk factors for what causes post-traumatic seizures, it's this type of injury. So it depends on what part of the brain was injured, if they have cerebral contusion, if they have any retained bone or metal fragments, if there's a depressed skull fracture, if there's focal neurological deficits, GCS less than 10, if there's a severe injury or length of post-traumatic amnesia, subdural epidural hematoma, and penetrating injury. And then lastly, age. Younger age has been found to be much higher risk for post-traumatic seizures. In regards to how to prevent it, we should try to start them on an anti-epileptic. The choices usually, what I've seen in the literature, is using phenytoin, fosphenytoin, or Keppra. A lot of the literature is kind of moving towards more so to Keppra, but there's no superiority between one drug versus the other. There's been a couple studies that have been done out of there. In regards to early prophylaxis with phenytoins, it's been shown in children to decrease early and late onset seizures. And Keppra, there's been a recent trial that was done, I think back in 2014, which looked at Keppra for 30 days post TBI and showed that the seizure rates were actually decreased at 2.5%. However, there's new literature coming down the road, and this is more particularly adults, where they looked at that seizure prophylaxis actually didn't have much of an effect. It actually led to a longer hospitalization, worse functional outcome, and didn't actually prevent the seizures. But similar studies have not been done in kids, and currently the guidelines do recommend early seizure prophylaxis. And the final concept of baseline care is in regards to nutritional management. In regards to nutritional, you want to start them in early nutrition, typically within the first 72 hours. Again, this can be difficult with a concurrent intra-abdominal injury or other injuries. So you might have to go parenteral or enteral. Enteral is typically preferred. But again, with the high dose of sedatives and paralytics, they have high risk of ALIA. So you always have to kind of be worried about that. The other important concept is to make sure they're normal glycemic. You want to make sure they don't go hypoglycemic. As you know, the primary metabolic fuel for brain is glucose, and low glucose will further increase the injury to the brain. And therefore, you want to avoid that. Hyperglycemia in general is associated with worse outcome in the critical care patients. They lead to more infection rates, long hospitalizations, and so forth. So therefore, you try to avoid that. In regards to that, you usually try to go for the bigger risk is hypoglycemia. So you want to target for normal glucose, but you want to make sure they don't get hypoglycemic or hyperglycemic. This is again going back to slide. The next part of the presentation, I was going to focus on the herniation pathway. In regards to the herniation pathway, you look for certain signs and symptoms, and this is something that you need to act on very quickly. You look for signs such as pupillary dilatation, hypertension or bradycardia or external extensor posturing, and you talk about the different types of treatment. In regards to herniation, it can really occur anytime during the injury. It can occur right at the scene or a couple days down when you're in the ICU. You look for signs such as Cushing's triad, which is bradycardia, hypertension, hypopnea. The important thing to know is that you actually start, when you have Cushing's, you actually get tachycardia first, which is the early sign of herniation, then leads to reflexive bradycardia secondary to hypertension. Just so something to be aware of. It's also key to be able to recognize signs of herniation, such as if you have transtemporal herniation, you get pupillary dilatation and bradycardia. And you have foramen magnum herniation, you get downbeat nystagmus, bradycardia, bradypnea, and hypertension. It's also important, that's why it's important to clinically examine these patients and look for these signs, because when you do see these signs, you need to treat them early and act quick. And this is a nice slide, and I'll quickly gloss over it because it talks about the different types of herniations. There's not just one. There's central herniation, which is swelling of both cerebral hemisphere, leads to early decline in consciousness, constricted pupils, and chain stroke. Then you can have cingulate herniation, which is displacement of the edematous cingulate gyrate under the falx cerebri, which leads to a whole variety of different symptoms, which I won't go into. Then you have tonsil herniation, which is the one we commonly think about, where the cerebral tonsils go through the foramen magnum. It leads to an abrupt loss of consciousness and opsiconic posturing, and can lead to even irregular respiration apnea later. Then there's also tensorial herniation, where the uncal portion of the temporal lobe is entrapped underneath the tentorial notch and leads to ipsilateral dilatation of the pupil and subsequently other signs as it progresses. In late stages of herniation, you usually get coma, flaccid limbs, mild unresponsive pupils, and loss of corneal and oculocephalic reflexes. In regards to management, the management is something we kind of talked about earlier. It's the same core principles. The first and easiest thing to do is just to make sure your head of the bed is at 30 degrees, again, to optimize venous drainage. Then you try to manually hyperventilate them with 100% FiO2 to prevent hypoxia, at the same time hyperventilating them to blow off CO2 to induce hypocapnia. At the same time, you can start hyperosmolar therapy, which you can use either mannitol or hypertonic saline. In the acute term, there's equivocal evidence you can pick either or. Mannitol, you can dose range is 0.5 to 1 gram per kilo, while hypertonic saline is 2 to 5. You can, if you have an extraventricular device, such as in the ICU, you can also lower it, as I previously mentioned. Usually lower it to the level of the tragus to allow for continuous drainage and drainage of the CSF to help with herniation. In regards to this, you also try to go for an urgent CT scan if the patient's stable enough to see what's going on. And if that's not possible, you do want to involve neurosurgery early, because this could be an indication to go for a decompressive craniotomy if it's not been done already. In regards to quickly talking about mannitol versus 3% normal saline, mannitol works in two different ways, which I didn't realize. One of the things that I found interesting was that the immediate action of mannitol works through decreasing blood viscosity, which leads to a vasoconstriction reflex, which occurs immediately and lasts for about 75 minutes. Then it also has this osmotic effect that decreases cerebral swelling, which occurs in 15 to 30 minutes and lasts up to 6 hours. But you do need an intact blood-brain barrier for this. Mannitol is generally recommended only when your serum osmolality is less than 320, and it's been used since the 1970s for management of ICP. In regards to complications, because mannitol is an osmotic diuresis, it can lead to dehydration, so you need to assess fluid status. It can also lead to acute tubular necrosis, and can lead to, and this is one of the bigger complications of mannitol, and this is why we don't typically run mannitol infusions for long, is essentially it can lead to, actually, if you don't have an intact blood-brain barrier, the mannitol component can actually linger in the brain tissue and lead to an osmotic shift the other way, so drawing in water from the extravascular space into the cells, leading to increased ICP and swelling. The other option is 3% normal saline. It again works in the same way. It has an osmotic effect, and you can actually use it at a higher osmolality, up to 360. It is thought to help restore normal cellular resting potential, and thought to have some effect in inflammation too. And you can give it as a bolus or an infusion to drive your serum sodium up, and which we'll talk about more in second-line therapy. The complications associated with normal saline is central pontine myelinosis. If you increase the sodium too quickly, can lead to renal impairment. It can lead to subarachnoid hemorrhage, natriuresis, or hypochloremic acidosis, which can all be negative. Another thing it does is it can mask diabetes insipidus if you're giving such high doses. And the other thing you think about is when you have high levels of serum sodium, and this is more so in second-line therapy, when you're driving your serum sodium up to 160s or 170s, you can have other complications such as DVTs or thrombocytopenia and anemia. And this is usually when it's driven this high for more than 72 hours when you have to think about these complications. This is, again, going back to the slide. We've covered the basic care and the herniation pathway, and I'm quickly going to touch on the rest of it. But this is, again, more ICU level care once they're driven to a tertiary care center. In regards to the ICU level care, you have to think about a couple of different things. So if you have a monitor and you want to, there's a couple of different pathways you can manage. First, you want to make sure both your cerebral perfusion pressure is maintained and your ICP is maintained. If your ICP is not is greater than 20 for too long, you can again use the CSF to drain ventriculostomy. You can bolus hypertonic saline. You can use additional analgesia, neuromuscular blockade, as I talked about, or you can give hypertonic saline. And if that doesn't work, you go to second line therapy. At the same time, you do want to maintain your cerebral perfusion pressure. So if your perfusion pressure is low, you can give volume to help increase it, or you can try vasopressors such as epi, norepi, or vasopressin. The other pathway, which I haven't actually seen and isn't commonly used in our ICU, is the PBRO2 pathway. PBRO2 is essentially a different kind of monitoring, and it monitors the oxygen in your brain. It's a different probe that gets placed in, similarly by neurosurge, and the goal is to maintain a oxygenation of greater than 10 milligrams of mercury in the brain. If you have a low PBRO2 and if you have this monitoring, you can raise it by increasing the FiO2, or you can again increase cerebral perfusion by using vasopressors to increase your PBRO2. Then quickly talking about second tier therapy. Second tier therapy, there's a couple different things, and I've kind of touched on them earlier in our presentation. One of them is when they're refractory, you can go into a barbiturate infusion, essentially making sure there's no metabolic activity. You can induce a hyperosmolar state, as I kind of alluded to earlier, where you drive your serum sodium into the higher ranges, close like 150 to 160s, to decrease your ICP. You can hyperventilate them to drop their PCO2. But again, as I mentioned, you don't want to do this for too long, as it can lead to more significant vasoconstriction and ischemic damage. As I previously mentioned, hypothermia to 34, 35 degree can also help. And lastly, you can go on to decompressive craniotomy. Decompressive craniotomy really can be done on any step of this pathway. It can be done initially. I couldn't find any clear indications of when they should do it, but typically it's done when you have refractory ICP, or if you have a big intracranial bleed that needs to be taken care of, or a depressed skull fracture that needs to go to the DOR. Again, I didn't focus too much on this, and I couldn't find much on the topic. This is just a nice slide saying what the secondary therapies are and what you should be concerning. And so the take-home messages from our presentation is that TBIs are quite common, but vast majority are minor injuries. All severe TBIs do need a CT scan of their head, and it's important to recognize severe TBIs to prevent the secondary injury. You need to monitor signs of herniation and promptly treat it. And early communication with a tertiary care center is very important, specifically with the trauma team and the ICU. And however, if it's a single system, you should involve neurosurgery early too. Again, the other big steps I put on is this slide is the 9 messages of how to initially manage increased ICP, which is again analgesia and sedation, prevent hypoxia and hypercapnia, normothermia, restore intravascular volume, adequate hemoglobin, treat coagulopathy, head positioning, seizure prophylaxis, nutrition, glycemic control, and then the herniation pathway being to recognize signs of herniation early and treat it accordingly. Any questions?
Thank you, Ayush. That was a very comprehensive and clearly stated overview of a complicated situation. And I really appreciate that. Folks, if you have questions for Ayush, please type them into the chat, and then you can ask. I'll ask everybody a question, and Ayush, this is some brownie points for you too if you get this one. Which province in which province in Canada, I beg your pardon, does not have booster seat legislation where the kids, between 5 and 9 do not have to be in a booster seat? There's one province. Does anybody know? What do you think, Ayush? Where would you guess?
I'm not sure. Alberta, maybe?
Yes. And someone else
I cheated.
Also got that one too as well. Alberta does not. And so if you have to be in a car seat till you're 5, but there's nothing after that. So there's a little something you can do in your spare time, you and Madeline, when you head out to Edmonton next year, is see if you can get some legislation there, because again, some of these tragedies are preventable, obviously. Any questions for Ayush? I'm just sort of looking here in the chat room.
I think there was a question from, I think that's Dr. Walling, and he's correct. It's hypercoagulopathy, not coagulopathy.
Right. Okay. Ayush, can you comment a little bit on any experimental research going forward in terms of blood-brain barriers or preserving viable neurons with any other, you've talked a little bit about, the basic physiology and sustaining that. But is there anything else that's sort of coming down the horizon that you might predict in the next 5 or 10 years, or maybe Simon and Dan, I think, are on the lines too, may want to comment on that as well.
I didn't find much. I think there's been a lot more research about monitoring. I didn't read specifically about blood-brain barriers, but what I found was there's a lot more different types of monitoring that's been going on. Like PDRO2 is becoming more prevalent. And then there's also a concept of looking at microdialysis and not to look at other compounds in the brain. That's the gist I found, but I didn't dig too much deep into it.
Okay. And someone commented that Dal is a leader in blood-brain barrier research. Alan Friedman, yes, is the dentist chair, who's also a neurosurgeon and a scientist who's in our department and works across the street. Good point. Oliver want to know if we can add the TBI management to TREC, and that's a good question as well. And probably, Oliver, that would be one, if we have any of our ED people. I don't know if Shannon McPhee is there today, or Katrina Hurley, but that's a good point, especially for people in the in our communities. David Simpson's asking, Ayush, evidence for managing perinatal brain injury has some differences from what was presented. Do young infants with non-accidental trauma act more like neonates or children?
I'm not sure. I haven't had too much experience. I've mostly seen teenagers to younger children with TBI. I don't know if, I know Dr. Kompotyk's here, if you can comment more to that.
I'm not sure who iPhone is, but someone said children. I believe that might be one of our neurosurgeons. I'm not sure. Oh, it's Christina. Thanks, Christina. Okay. Any other questions, folks, for Ayush? Ayush, do you have a sense from your time spending in PICU, and maybe Christina can back us up, or Dan or Simon, in terms of what age groups do we tend to see in the PICU with brain injury? Is it mostly the under 5s, or is it mostly the teenagers, or just a little bit of everybody?
I didn't find anything specific, but I believe it's a little bit of everybody. But again, Dr. Kompotyk might be able to comment more on that.
Okay. And Jen or Christina, do you have a sense of who we see in our PICU here in terms of the sort of the larger groups? ATV, there you go. Often kids are riders. That's from Jen. That's from Christina. And that's another issue. There is a law in Nova Scotia about kids under 16 not being riders. I don't think it's really enforced. And every year or two, we see some pretty horrific injuries from that one as well. ATVs are not toys. And I've often encouraged my parents in rural Cape Breton, if you're going to get your kids something, if you're bound and determined, if it's not a cross-country type of bike, even a small dirt bike, if the kid is 10 or 11, that has a controller on it so it can't go too fast. But man, oh man, those ATVs, when they roll on you, it's bad news. It's bad news. And Simon makes the point about injury prevention being money well spent. And that's where we can come as surgeons, intensivists, and pediatricians with these stories and the stats. The stories help persuade our legislators. And I think Natalie Yancher years ago was a big ATV legislation proponent. She's one of our general surgeons who's since moved west. But it's definitely worth the time. And I'm sure our intensivists and neurosurgeons would tell you about the heartaches of those kids who are lucky enough to survive, but the long-term consequences for those children and their families when they've had a serious head injury. Usually they don't get away scot-free. And so we do need to spend some time both being experts at treating, but experts at advocating as well. Simon asked, which province has the most comprehensive helmet law for kids? I'm not sure if you mean ski, bike, or whatever, Simon. Do you mean right across the spectrum? All, yeah.
Oh.
I'm going to say Nova Scotia might be, but I could be wrong about that. Simon, if you know the answer, go ahead, put it in. Yes, I think it is Nova Scotia. There you go. So that's probably because of people like Simon and his colleagues and others who've been pushing for that legislation. So just remembering again, that's part of our duties as people who care for children, is to do the prevention part and the advocacy part. I think what I'll do, we've got 2 or 3 minutes left. And Kevin, thank you, Ellen. Kevin Gordon, who recently retired, one of our pediatric neurologists who's a concussion specialist, obviously pushed for this as well. And that's true for checking and Pee Wee hockey. Kevin had a lot to do with that as well. So thank you one and all. And Ayush, thank you for, that was a fantastic presentation. It'll be recorded, folks, that you can see this on our YouTube site. That is in the email that goes out from my office here. So once again, Ayush, thank you. Best of luck in the future. I'm sure you're going to be very well suited to a career in critical care medicine. And have a great day, everybody.
Thanks.
Well done, Ayush.